Hello everyone, in this video we'll be discussing the TMJ disease and their surgical aspects. So first of all, what is TMJ? So TMJ is nothing but it is a bilateral diarthrodial joint, right? And it is a joint between the mandible and the temporal bone. Okay, so I'll be going in more specific details now. So it is basically the articulation between the squamous part of temporal bone. So the squamous part of temporal bone has a fossa known as the mandibular fossa or the glenoid fossa. Okay, so it is known as glenoid or mandibular fossa, and in this particular fossa your condyle of your mandible is going to articulate. Okay, so there will be articulation between the squamous part of the temporal bone, and there will be the other articulating part is the head of the mandibular condyle. So if we see here, this is your temporal bone, and more specifically it is the squamous part of your temporal bone, and it is having a fossa. Okay, so this fossa is known as the glenoid fossa or the mandibular fossa, and this is going to articulate, or your condyle of the mandible is going to articulate with this particular fossa. We will be getting in more details of the anatomy of this joint, although we have discussed the anatomy of the temporomandibular joint in dental anatomy part also, but as and when need is required, we'll be discussing these also. So there are some parts like articular disc also, which is going to interpose between the your fossa and your condyle. So this is something about the articulation, or we can say the temporomandibular joint. Now the mandibular articulation is labeled as a bilateral diarthrodial, or sometimes it is known as the freely movable joint. So this can be a direct question in your exam if it is a simple thing about the TMJ. So before we go into the depth of the pathologies of TMJ, let me give you an overview of the normal anatomy of your TMJ. So this is your condyle, right, which we have just discussed. This is the condyle, this is the condylar head, this is your glenoid fossa. Okay, now glenoid fossa will be covered by a membrane known as the synovial membrane. Okay, so that will be covering the synovial membrane. Okay, and same way your condylar head will also be covered by the synovial membrane, and there will be these two articulating surfaces will be covered by a membrane known as the synovial membrane. And those who have given NEET 2021, they must have got this figure, because this exact figure was asked in the exam also, right? So now in between these there is a intersposed disc, and that disc is also known as the meniscus. Okay, now meniscus can be divided into three parts: anterior, middle, and your posterior part. Now most important thing, the anterior and middle part are mainly avascular, so they are not going to have too much blood supply or nerve supply, and that's the reason when it rubs over this, your condyle rubs over this, it is not going to cause pain in normal conditions, right? Now sometimes what happens, the posterior part becomes flaccid, and sometimes the posterior part of the meniscus come in the contact with the condyle and the glenoid fossa. That time there are chances of inflammation and pain. So that we'll be discussing as and when need is required. Now this one is your lateral pterygoid. The upper one is the superior head and lower one is the inferior head. The synovial membrane, of course, it is covering the condyle, and here it is covering your glenoid fossa. Now the posterior capsule. Now this area, this one is the posterior capsule, and basically we can also say sometimes the posterior part of the disc, the meniscus which we are having, it is going to have some vascularity, and that can be a potential question in your exam. Now let's discuss the classification of the TMJ disorder. So first thing here is the intra-articular origin or intrinsic disorder. Now intrinsic disorder basically means it is within the capsule. Okay, so it is within the TMJ capsule, whatever is happening in the articulating surfaces, right, and within the articulating space, that is termed as the intra-articular origin. So first thing, there can be trauma, and due to trauma there can be dislocation, subluxation, hemarthrosis, and intracapsular fractures, as well as extracapsular fractures can also be considered. Then the internal disc displacement. So what happens, as I have already told, that generally the anterior or the middle part is in the contact of your head of the condyle, right? Now, sometimes what happens, this disc becomes displaced anteriorly, right? And that is known as the anterior disc displacement with reduction. So when it is like self-reducing, okay, it gets back to the position when we retrude the mandible or the condyle is not functioning. So that is known as with reduction. And sometimes what happens, anterior disc displacement occurs, but it is not reducing. Self-reducing reduction is not there. So if it comes anteriorly, now when the condyle is not functioning and the condyle is in rest, then also it is not reducing with the condyle. It is not getting back to the its original position. So this is basic difference. So what is going to happen in these? There will be, of course, anterior disc displacement. One is with reduction and another is without reduction. Now the second thing could be the change in the texture of the bone. So what happens if there is arthritis? So it can be osteoarthrosis, in which the degeneration of the bone, the articulating bone may occur, right? And that is known as osteoarthritis or degenerative arthritis. Both can lead to the degeneration or changes in the surfaces, the articulating surfaces actually. Same way, rheumatoid arthritis, juvenile rheumatoid arthritis, as well as the infectious arthritis, all these are going to change the surfaces of the TMJ articulating surfaces, so the glenoid fossa or the condyle, and that is going to create problem. Then we have the developmental defects. So sometimes what happens, there is condylar agenesis. So there is failure of development of the condyle in a person, and that's why there will be a lack of articulating surface, right? Or there may be aplasia. Okay, so agenesis or aplasia might be there. The condyle might be anatomically different. That means it may be bifid condyle. Then there can be condylar hypoplasia or condylar hyperplasia. So in some cases the condyle is forming, but it is not forming completely. The size is lesser than the normal, and sometimes it is more than the normal. So all these are the derangements which are due to the congenital problems, or we can say the developmental defects. Now the diseases of the extra articular origin, so that is of course beyond the scope of the TMJ cavity, or we can say beyond the scope of the capsule, right? So what can be that? The problem in the TMJ, because of the structures, the defects in the structures which are not within the TMJ capsule, but these are beyond the TMJ capsule, and that is known as your extra articular origin or extrinsic disorders, right? So first of all, masticatory muscles disorders. So as we know, there are 4 muscles of mastication, and these muscles are responsible for movement of the jaw, right? So the condyle, directly or indirectly, it moves through these muscles only, right? Now, so what happens if there is protective muscle splinting, or there is masticatory muscle spasm, that is seen in the MPDS, or there is masticatory muscle inflammation? All these are the masticatory muscles disorder. Sometimes there can be neoplasm, okay, and these neoplasms can be beyond this particular TMJ cavity, and that is benign tumors can be there and the malignant tumors can be there. Benign tumors like osteoma, osteochondroma, chondrosarcoma and fibrosarcoma, these two are the malignant tumors. So if we see the diagram here, so we can appreciate when the mouth opens. If you see the mouth opens, the normal position of the condyle should be here, and it should be the middle portion of the meniscus, or you can say the disc, should be in contact with the condyle. Okay, we can appreciate it here. Now sometimes when pathologies are there and there is problem with the disc, as I have told that there is anterior displacement of the disc without reduction and with reduction, right? So if we see what happens when there is a anterior displacement of the disc, this particular disc comes forward, right? And the middle part is not in the contact of your condyle, and during opening, what will happen? The bones will have friction because the disc is not there to give the cushioning effect, right? So bones will have friction, and that can change the morphology, or we can say the surface structures of the bone, and that can lead to the problems. That is one of the TMJ problems. If we see here, this is condyle, this is your disc. The normal position is in the center of the disc, and this one is your superior joint space, and sometimes there is an inferior joint space which is there. So these are asked in the exam sometimes, right? So what is the function of your meniscus, or we can say the disc? That is basically providing a cushioning medium or non-frictional medium so that there can be synchronous joint movement. So what happens if there is a problem with this particular disc? That may lead to the friction of the bones together, the articulating surface of the bones together, that can change the texture of your bone. Now, before moving forward, we should try to use that knowledge, whatever we have gained till now in this part of video, right? So whatever I have told you, let's try to implement that particular knowledge and try to understand what are the pathologies of the TMJ. Okay, so first of all, as the name indicate here, TMJ internal derangement. So TMJ internal derangement means there are going to be problems within the internal area of the TMJ. That means within the capsular space, we can say, right? So there can be changes with the condyles, there can be changes with the disc, there can be changes with your glenoid fossa, right? So first, let's see the etiologies. So TMJ internal derangement, primarily it is due to the rheumatoid arthritis, post-traumatic arthritis. So out of these, post-traumatic arthritis is the least common, but generally these are caused by the arthritic changes of the bone. Secondarily, there can be derangement that can be caused due to the problem in the muscles. That can be first, the primary cause is the extrinsic one, but later it can lead to the problems in your TMJ also. So secondary to MPDS also there can be some TMJ internal derangement. So what are the clinical features? How will you understand? Actually, there is pain, okay, facial pain. That is one of the most common clinical feature of the TMJ derangement, and that cause a very that needs a lot of skill or not a lot of investigations to understand whether it is a TMJ pain or some other facial pain. So it becomes very difficult. So you have to be very particular, taking the history of the patient and doing the correct laboratory findings also. So clinical features: pain in and around TMJ with jaw bone, right? Altered movement of jaw can be there, and often it is restricted actually. Joint sounds can be seen, crepitations and clicking. So clicking noise of the joint can be seen, but before that pain will occur. Okay, sometimes what happens, clicking can be there without pain also, but pain is something that is going to be the most common presentation. Often patients have clipping, but they do not come to the dentist for checkup, right? So pain is something that is the most common presentation of this particular TMJ derangement. Yes, clicking can be there, cannot be there. Crepitations can be there, cannot be there. So how you will reach to the diagnosis? First, you will have to check the patient intraorally, clinically. Complete examination should be there. Complete muscles examination, muscles of mastication examination should be there, and you have to take very proper case history. Okay, then you will have to do the MRI. So MRI for what? For the disc, because MRI can detect the soft tissue structures. So for that, check the disc, okay, and then you can know the disc and condyle relationship. Any derangement in the disc, any arthritic changes in the disc, or any internal inflammatory changes in the disc can be found from the MRI. Then we'll see the CT. Now CT is going to check for the bones, so that is going to check your arthritic changes of the joint. So basically your TMJ joint is going to have two things. One is the bones. What are the bones? Glenoid fossa is of course a bone, and your head of the condyle is of course a bone. For that we will require CT. And if we have to check the soft tissue, which is the soft tissue which is present within the capsule, your yes, synovial membrane is there, but yes, more importantly your meniscus or the disc is there, that might have the problem, and that's causing the actual TMJ pain, right? Now position of disc, it should be at 12 o'clock position on the condyle. So I have already told that the condyle should be at the while opening also, it should be in the middle of the disc, right? If and we know the anterior and the middle part is almost avascular, so that's not going to cause pain while the movement of the jaw occurs in normal conditions. But what happens there when there is problem or change in the relationship of the condyle? Sometimes what happens, posterior part of your disc comes in the contact of this your condyle, and there we have certain nerves and capillaries, so they might transmit pain or at least transmit the inflammation at least there. Now, what are the factors that maintain the positioning of the disc? So, there are two factors. One is your retrodiscal tissue. Suppose this is your disc and this is the retrodiscal tissue and anterior lateral pterygoid. So, it is going to move this particular disc anteriorly, while the retrodiscal tissue will do the recoil and there will be posterior movement. So, there will be a balance that will be required for the proper function. So, there should be balance between the functioning of anterior lateral pterygoid as well as your retrodiscal tissue, so that your disc can be maintained in the proper position, right? So, for the anterior, you will remember the lateral pterygoid, and the posterior you will remember the retrodiscal tissue, and balance between these two will be maintaining your meniscus in the correct position. Now, you have already heard about the anterior disc displacement. So, what do you think can be the cause of the anterior disc displacement? Yes, anteriorly, if there is very strong pull of your lateral pterygoid, then yes, disc can be pushed anteriorly. Or another reason can be the lateral pterygoid is having the normal pull, but your retrodiscal tissue is weak, right? So, that is not able to recoil it properly and hold it properly, hold the disc properly. So, weakening of the reciprocal tissue, or the weakening of the retrodiscal tissue is going to affect your positioning of the condyle. So, these two things are there. Strong pull of the lateral pterygoid and weakening of the retrodiscal tissue will be causing the anterior displacement of the disc. Now, therefore, normal disc condyle relation is disturbed whenever there is a problem with these two structures. One is your lateral pterygoid and another is your retrodiscal tissue. Now, the condyle which rubs against the disc. So, sometimes what happens, actually while moving, the middle part of the disc will be with the head of the condyle like this, and both will move together while opening the mouth, right? During the opening of the jaw, the anterior movement of the translatory movement of your head of the condyle will occur, and that will keep the middle portion intact to it, and this middle portion of the disc will flow or translate with the condyle. But sometimes due to problems, internal problems, yes, there can be rubbing of the condylar head on the surface of the disc, and that can lead to the clicking or crepitation sound. So, you might be wondering why this clicking and crepitation occurs. Yes, there can be a reason due to the condyle rubbing against the disc. So, if clicking occurs during the opening of the mouth, so when we open mouth, what will happen? The condyle will translate towards the anterior aspect, right? So, that is known as the forward clicking. Sometimes clicking is seen during the closure of the mouth, and that particular clicking is termed as the reciprocal clicking. Now, how will you approach for the treatment of such condition? Yes, you want to make that disc and condyle relationship proper, right? So, how it can be done? It is of course directed towards the harmonization of the disc condyle relationship, and there can be occlusal splint therapy, TMJ anthrocentricis, or there will be botulinum toxin A injection to analyze the lateral pterygoid muscle. So, what is this? Actually, botulinum toxin A is a muscle paralyzer, okay, transient muscle paralyzer. So, you can inject that and you can check the strength of the lateral pterygoid muscle. Sometimes the anterior displacement of disc occurs due to the higher strength or more strength of your lateral pterygoid. So, if you provide, you put that particular injection in this, so there will be paralysis of the lateral pterygoid, and that will be causing weakening, transient weakening of the lateral pterygoid. So, you will be able to diagnose whether it is due to the higher pull or higher strength of your lateral pterygoid. So, another thing, if it is not working, these things are not working, then you have to opt for surgery only, then open joint surgery, in which the repositioning of the disc is aimed, and there can be meniscectomy, but nowadays it is not recommended now. So, why do you avoid the meniscectomy? Yes, because your interpositional disc, your meniscus, is going to provide the cushioning effect, and it will avoiding any direct rub between the condyle and the glenoid fossa, and then there won't be any to avoid any kind of structural changes in these two bones due to the friction, right? So, if friction is there, there will be more damages. So, you have to understand that there is very important aspect, that is the partition is required, and that partition should be due to the meniscus only, and there should be a cushioning effect on the two bones. Otherwise, if they are in direct contact, they might create problem, right? So one thing known as the TMJ orthocentesis, that is known as the joint lavage. So basically what is joint lavage? It is cleaning or flushing the joint with the normal saline or any sterile liquid, and to flush out the inflammatory things. Okay, so there might be some inflammatory mediators within this. So to flush out all those things, we use the joint lavage, that is known as your orthocentesis. Another important thing which we have already discussed, that the main principle of this whole management is the harmonizing the relationship between the condyle and your disc, right? So if there is disharmony, what's going to happen? There will be constant trauma that will be present, that will be leading to the inflammation, and more inflammatory mediators will be there in the joint cavities. That's why we'll be putting, there will be a lot of chemical mediators, inflammatory mediators within the joint cavity, and that is going to of course cause the pain. So if pain is there, yes, there will be problem, as well as these increased inflammatory mediators will be causing further damage to the synovial membrane, and that can lead to the fibrosis and adhesion, because there will be altered function of the synovial membrane. To avoid this, we can do the lavaging with the normal saline or the normal chemicals, so that we can flush these chemical mediators out. So by now we have understood that the most of the pain is due to the increased chemical mediators, and I have already told that we can use some sterile liquid that do not affect the TMJ anatomy, of course. So for example, normal saline, another liquid is Ringer's lactate, and if we compare the efficacy of both, Ringer's lactate is preferred over the normal saline. Okay, so why we are doing the orthocentesis? Because of the, we want to wash out the chemical mediators of the inflammation that is present in the TMJ cavity, right? And another important thing which is the aim of this orthocentesis is it to break the fibrous adhesion to the joint. Why? How? By physical action. So when you will be putting water or putting your normal saline or Ringer's lactate with force, there will be some physical force, and that physical action can lead to the breakage of any fibrous adhesions that are occurring there in the TMJ joint. Because of, so what is the reason? So this is not a chemical action, but the physical action that is due to the pressure of the liquid. Okay, so these two things will be giving the relief in pain, right? Now what are the liquid? Yes, any sterile liquid can be used, but Ringer's lactate is more preferred than the normal saline, which I have already told. The Ringer's lactate in normal saline does not alter the chondrocyte metabolism, and that's why they should be used in the TMJ, right? So Ringer's lactate will be used for flushing of the bone. While cutting, it is more expensive than normal saline. This is the only disadvantage. Otherwise, if we compare normal saline and Ringer's lactate should be preferred, not only for the orthocentesis but for the irrigation purpose also, which we are doing during the cutting of the bone. So as we know, there are two cavities or two spaces within the TMJ, the superior joint space and the inferior joint space, and that is divided into superior and inferior by the meniscus, right? So superior joint space is going to have almost 1.2 ml of synovial fluid, and the inferior one is going to have the 0.9 ml of the synovial fluid. So when we are doing the TMJ orthocentesis, generally it is done in the superior joint space. Nowadays, some authors say that it has to be done within both, because the whole area is going to be flooded with the chemical mediators. So why to do for the superior only? You can do the superior as well as inferior joint space lavage also. So this TMJ orthocentesis was first done by NISM, and TMJ orthocentesis can be done by either single needle technique, or we can use the two needles. Okay, one is for the inlet and another is for the outlet, and it is a better and efficient lavage. So what are the adjunctive drugs we are going to use with the orthocentesis? So there are two problems actually. One is your fibrous adhesion and another is your flooding of the area with the chemical mediators. For fibrous adhesion, you can give something that will break the fibrous adhesion. So that is your hyaluronidase. And for your chemical mediators, you can give something that will be having anti-inflammatory action. So that will be your corticosteroids, right? So first thing, hyaluronidase, also known as the Hyalase, the brand name, and capable to break the connective tissue barrier, that is your fibrous adhesion. Then you have the corticosteroids, that is your methylprednisolone, and it is going to have very marked anti-inflammatory action, and that is going to act against the chemical mediators of the inflammations, and that's why it is going to decrease the pain production, right? It generally produces by the kinin mechanism, right? So we can read about it more in the pathology. Now, what are the disadvantages of this particular arthrosynthesis? Actually, repeated use can lead to the arthritic changes in the joint cavity. So, what are the structures that are going to be affected? Of course, your glenoid fossa and your condyle. So, multiple use is not recommended, and if you are going to give the second injection, if second injection is also required, second lavage is also required, period or gap between these two lavages should be of months. Now let's discuss certain important questions based on this topic. So first question here is, how does TMJ lavage helps to break fibrous adhesion? So we have already discussed that we'll be flushing the TMJ cavities. Majorly we do it for the superior, but yes, it is advised that both the superior as well as the inferior TMJ cavity should be flushed, right? So when we flush this, we use certain sterile materials. So generally ringal lactase is used, or we can use the normal saline. So when we put the liquid inside, there will be a pressure buildup, right? And that pressure by physical action breaks any formation of the fibrous tissues within the TMJ cavity. So how does TMJ lavage help to break fibrous adhesion? By the physical pressure or the physical pressure of the liquid, right? Then what is the role of prednisolone in internal derangement of the TMJ? So whenever there is more inflammatory mediators within the TMJ cavity, we can think of giving some anti-inflammatory drugs. So of course prednisolone is a corticosteroid, and it can have marked effect in reducing the chemical mediators of the inflammation. So that's why we are giving it. We give one more chemical as an adjuvant to the TMJ arthrosynthesis, that is your hyaluronidase, and this is also going to break the fibrous tissue chemically. Then we have, what is the reason of clicking of TMJ? So we have already told that generally when we open the mouth, right, your condyle will be translating on the front side or towards the forward direction, right? So what will happen? Your disc, the middle portion of the meniscus, will be in constant touch of the condyle, and it will move with the condyle constantly, and there won't be any rub in normal condition. But what happens when there is problem with the disc, or there is a problem in the relationship of the condyle and the disc? That time your condyle will rub on the disc, that can lead to the production of the sound that is known as the crepitus or the clicking.